Thank you, Mr. Speaker, the Honorable Speaker of the National Assembly, the leadership of the House, Honorable Chairpersons of committees, distinguished members of Parliament, ladies and gentlemen, good afternoon. It's a distinct honor first for me to stand before this august House today, and I do it so with a very profound sense of gratitude. The journey to transform Kenya's health care system has been long and tedious, but it's a journey we have walked together. This House has been the bedrock of that transformation. Without your legislative wisdom, your oversight, and your bipartisan support, the milestone we celebrate today could remain mere aspiration. And for that, Honorable Speaker, I want to say asanteni sana, and we are happy that you stood with us. Honorable members, our mandate basically is anchored in the better agenda, the bottom-up economic transformation. When this administration took office, we made a very solemn vow that healthcare will no longer be a privilege for the few who can afford it, but a constitutional right for every Kenyan, as it is enshrined in Article 43. Health is not just a social service, it is a key economic pillar. And I say that with conviction that a healthy nation is a productive nation. We committed to shifting the paradigm shift from curative to preventive care, and from catastrophic out-of-pocket expenditure to social insurance model that leaves no one behind. To realize this, Honorable Speaker, this House undertook a historic legislative marathon. You debated, you refined, and you enacted 4 crucial laws that now form the legal spine of our healthcare system. And that is the Social Health Insurance Act of 2023 that established SHA and replaced NHIF, the Digital Health Act of 2023 that created the Digital Super Highway for Health Data, and the Primary Health Care Act of 2023 that operationalized the hub and the spoke model and the community health promoters. And finally, more importantly, the Facility Improvement Financing Act of 2023 that ensured funds raised in hospitals stay in hospitals. Honorable Speaker, let us be very honest about where we came from. Prior to these reforms of this administration, our systems was ailing. We had a very fragmented financing model where NHIF paid out more in fraudulent claims than it collected in legitimate premiums. We had no visibility of the patient data. We had no visibility of the patient records, and patient records were paper-based. Making portability was impossible. When I first stood before the ministry during my maiden speech on 1st of April 2025, the situation was critical. We were 6 months into the Taifa Care rollout, facing public scrutiny and systemic roadblock. I told the country then that, and I was given a name that I am a bulldozer, and that was for the right reason, to clear the way for universal health coverage, but to crush the bureaucracy and to build a system that works. Today, I return to report to the people's representative how that ground has been cleared, what we are building upon it. And I want to start with the first pillar, the pillar of sustainable health financing. I wish to begin with that pillar, and the transition from NHIF to Social Health Authority is the engine of our reform as an administration and a country. The numbers tell a story of unprecedented success and stability. As of 26 January 2026, we have registered 29 million Kenyans into the Social Health Authority. This mass registration has translated into tangible financial health for our system. We have collected 130.4 billion in contribution. And critically, we have disbursed over 93.4 billion to healthcare providers, both in public, in private, in faith-based, and in our national referral hospitals. Contrary to the inefficiency of the past, we are making great strides in settling all verified, validated claims. Currently, we have achieved an average claim settlement rate of 73% across the board. This means that money is flowing to our hospitals, ensuring that facilities remain stocked and operational. Honorable Speaker, as I say that, I want members to be cognizant of the Schedule 4 of the Constitution, that health is a shared responsibility, that health is a devolved function. A key component of this financing model was the realization through this House of the free primary health care, which has never happened in our country before. We are currently rolling out service charter to primary health care facilities across all the 47 counties. And we are doing this from last week because Kenyans go to primary health care facilities, level 2 and level 3, that's the dispensary and the health center, but they are forced to co-pay. It's supposed to be walk in and walk out. So we have created now a charter, a green label charter, which we are going to fix, and we have started with the Bomet last week. We'll fix it in every level 2 and level 3 public, private, and faith-based health facilities. This charter, and I want to highlight that Bomet Health Center, which has the distinction of being the first facility to successfully roll out this charter. This charter is our promise to the people that at level 2 and 3 facilities, a Kenyan citizen should be able to walk in and walk out as an outpatient without paying a single shilling. We have already seen 800 million Kenyans have accessed services at the Primary Health Care Fund, proving that when financial barriers are removed, our people will seek care early, preventing complications and saving lives. To ensure that this safety net covers everyone, including Mama Mboga and Boda Boda riders, Honorable Speaker, in June of 2025, during Madaraka Day in Homa Bay, President Ruto launched the Lipa Sha Pole Pole initiative. We understood that the informality of our economy requires flexibility. This innovative payment model allows Kenyans in the informal sector to make a small, manageable contribution towards their health cover rather than a lump sum. This has democratized access to insurance, ensuring that economic status is no longer a barrier to quality health care. We are currently having over 410,011 active payers utilizing this Sha Lipa Pole Pole. And so far they have contributed over 1.4 billion, a clear indication that Kenyans are willing to pay for their health when given a dignified option. We are also committed, Honorable Speaker and members, to ensuring that the most vulnerable among us are not left behind. The national government is currently sponsoring over 558,000 indigent households, picked from the social health protection data in all our villages and all our counties and constituencies. And those 558,000 indigent households are having the Social Health Insurance Fund premium cover. I must also commend a number of counties, and one of the best counties, Muranga County, which has set a gold standard by fully meeting its statutory obligation and sponsoring over 38,000 indigent households and remitting their full annual premium of the SHIF. And we asked more other counties, Makueni County, Kisumu County, most of our other counties are also preparing their list between 10,000 to 20,000 indigents so that they can pay for. Honorable Speaker, furthermore, through the INGAF, through the national government, CDF, a number of members of parliament have paid for indigents from their constituencies. And you can see the list here. And there are more that we are going to post. And I have asked the CEO, Honorable Deputy Speaker, representing a number of our women rep, has also submitted the list. And I've asked the CEO of SHA to make a dedicated desk and staff to attend to members of parliament, starting tomorrow once this workshop is finished, so that the figure is known, the figure has been agreed, and is a flat figure, and we want in your constituencies to give us the list. If you tell us to pick it from the database, we will pick it from the database, social protection, but we want our members of parliament, and they have been doing it even before. But right now, because members are asking me, how do we do it? I have directed SHA, now that they have a skeleton staff, to dedicate a specific desk that, and even come to parliament. The clerk of the National Assembly, through the speaker, can even give us a room within parliament where the SHA members can be accessed by members of parliament. Members of parliament do not, even their offices, your staff can access our team in parliament, but we really want. We have collectively together, we are sponsoring partners and development and philanthropies are sponsoring close to 62,000 if I add with the ones of members of parliament. But I want to urge the honorable members to utilize the national government CDF to sponsor the indigent in your constituencies so that we mirror this success to ensure the universal coverage. Honorable members, for a long time, the overseas treatment scheme was a conduit for abuse between doctors in Kenya and hospitals in India and many other places, where cartels and these agents exploited the vulnerable patient and the public purse. That era is over under SHA. We have introduced a robust, transparent framework for overseas referrals that put the patient first and protect our resources. This new policy, Honorable Speaker, is anchored on a simple principle. SHA will only pay for overseas treatment if that procedure is not available locally. Because when you go to India, you are supposed to go with the whole family. It's more expensive for the family, and that is why we have to do a lot of harambe. And to enforce that procedure, I have appointed the Benefits Package and Tariffs Advisory Panel, a team of top experts who have vigorously assessed our local capacity. And I am pleased to report that the panel has successfully identified and listed only 36 medical interventions that are currently not available in Kenya. And these are the only conditions for which SHA will authorize treatment abroad. If you want to pay for yourself, it's okay. But under SHA, it must fall within the 36. The only conditions which the law allowed us. We have also introduced a very strict vetting protocols. Every referral is now subjected to a peer review by the claims office to ensure that the medical necessity is found. Honorable Speaker, we are also requiring that any overseas facility receiving a Kenyan patient must also formally empaneled and contracted by SHA. So you cannot go to India and walk to any hospital. The way we contract Aga Khan and Kenyatta Hospital, the facilities in the foreign nations must come and contract with SHA. And we do it online. Honorable Speaker, we have capped the minimum payable amount for this overseas treatment to 500,000. This will ensure the sustainability while granting access to life-saving procedures. This new framework guarantees that we are not going to exporting our patients and also exporting our money to support healthcare system of other nations. And let me repeat it. We will not export our patients and our money to support healthcare systems in other countries. We must be candid. We must improve our healthcare system so that the money can remain here and support our health facilities. Our patients can be at home, and many members know during the COVID, we could not even return the bodies of our loved ones when they pass in India. Because in some countries, the only thing that happens is cremation. Many Kenyans, particularly of the Christian faith during COVID, they could not bring back their bodies. Airlines have refused. Countries have introduced protocols. So we must build Kenya. We must retain our patients here, treat them, and we must retain our money. Honorable Speaker and members, the transition from NHIF to SHA is not merely a change of logo. It's a fundamental restructuring of our national health insurer to ensure efficiency, integrity, and professionalism. We are building a new institution from the ground, and this requires a fresh, competent workforce. And I wish to be categorical. Recruitment into SHA is strictly based on merit, unlike the NHIF, unlike the defunct NHIF. There is no automatic transition. However, Honorable Speaker, we were guided by the courts. The former staff of NHIF went to court, and we were guided by the law and the courts that we must give priority to competent, qualified former NHIF staff. The days of nepotism and incompetency are behind us. Only those who prove their worth will serve the people of Kenya. And Honorable Speaker, to make the record straight, to date we have only recruited 144 staff members, representing 17% of the total approved establishment of 815 positions. The initial phase focused on securing the top leadership and the core leadership and the technical experts needed to operationalize the authority, including the CEO and the directors. We are now doing a massive recruitment drive for 425 senior officers in order we decentralize them to our counties. And this exercise has been highly competitive. We have received 17,434 applications, and we have, following vigorous shortlisting process, we have shortlisted 1,737. And Honorable Speaker, I want to categorically say the list that is circulating in the social media is a fake list, is not from SHA. And I am ready to present the truth. Yeah, there are people who doctored that list in terms of counties, in terms of tribes, for their own reasons. I have a full report before Parliament, and I'm ready to submit that. That list is fake. That list is meant. The people who could not say anything about SHA, they have looked for anything under the sun, and they have generated a fake list. And I'm ready to appear before the committee of even cohesion and integration. I think that committee still exists in the House. Yeah, I'm ready to appear before that committee and put everything on the table. But that thing which is going round is not from us. Honorable Speaker, let me go to the pillar number 2, comprehensive healthcare information, digital superhighway. This superhighway has been the game changer in our history, where for the first time, visibility of our healthcare sector, all our 47 governors, the whole leadership of MOH, the president himself has a digital dashboard that he can follow what is going on in the health sector. And Honorable Speaker, if you allow us, we can give Parliament also a dashboard that can be put somewhere. You can see even the bed occupancy of Kenyatta Hospital. We have successfully, up to today, digitized and linked 10,277 transacting faith-based and private hospitals into one digital superhighway. We have specifically have 4,149 public facilities that are now fully digitized, because slowly we are training and we are digitizing them as we move along. And to support the Taifa Care system, we have delivered 30,087 digital devices, including the biometrics. And that's why you see, Honorable Speaker, under SHA, there's no card. Honorable Speaker, under SHA, there's no card. It is your thumb. Particularly now we have finished level 5 and digital devices I'm talking about across the country. And this is to ensure that the mosque can transact data in real time. Honorable Speaker and members, this digitization is not just about efficiency, it's about the potent weapon against corruption. The era of manual claims, opaque processes allowed theft to thrive. And that's why you see in today's headline, the 11 billion shilling lost between October when Shah kicked off to April when I took over, the system did audit. And we found facilities were stealing because they were used to stealing from NHIF. And how do they steal? So that 11 billion is rejection. We have presented. So that 11 billion is rejection. We have presented to the committee. And I'll give you what are rejections. There are facilities in our country that have reported 100% of the mothers who came to deliver have gone through C-section. That is even against the WHO rule. The WHO rule, international accepted, is 10 to 15% of mothers who go to deliver in hospital will go through C-section. And I think the member for the vice chair of health committee, Honorable Pato, is here. When I went to Tharaka Nithi, one private hospital said 500 mothers came here, all of them delivered through C-section. If that happens, it's against the law. The former chair of health committee, Honorable Sabina, is looking at me. Shah will not pay. Secondly, we have hospitals who are saying they want to be paid for maternity and they are not providing two very important documents. The first document is the claim form. Claim form is in the law that you have passed. And even you, when you go to your doctor, a claim form, a legal document, is filled by 3 people. The patient must fill. You have seen your doctor or your nurse after they take the normal thing they tell you fill. Then the doctor fills. Then the hospital administrator fills. A situation where we find, Shah finds that claim forms are filled by one person, one handwriting, one pen. That is a rejection and we will not pay. It's part of the 11 billion. Thirdly, there are people who are submitting that maternity delivery has taken place in a facility. And any healthcare worker listening to me will know that when a baby is born in a facility, and there are doctors in this August house, there must be a very important document called birth notification. If you submit claim forms for maternity and there's no birth notification, how are we sure that a child was born? That is a rejection. We will not pay. It's part of the 11 billion that you saw today the nation has carried. Finally, the last one is when people make claims on surgery procedures that somebody has gone through the theater. There's something called theater notes. And you have seen, as the person is being taken to the theater, there is a file on top of the patient. That file carries the theater notes. So if you don't submit the theater notes to be part and parcel of your claims documents, how will Shah be sure to pay that claim and that procedure and surgery has taken place? I will tell you of something, even PhD, the primary health care facility, which is free outpatient. Now, you know, the system picks patterns. It's not human beings. These days, there are not claim forms. You know, under NHIF, the claim and everything was done at the counties, by manual, by people. And they sit together. Now the system picks patterns. And this morning, we have picked a pattern. Let me just add it. In fact, half of my team don't know. In primary health care, in one of our counties, we have picked, there's a patient who's accessing one of our dispensary or our health centers in that county, in that facility, 10 times a day. Yes. The how is a rejection. The how is a fraud. The how is the 11 billion that we have. We have just picked it. And we have said it, we will have a conversation with the governor of that county. Because he wants to get more capitation, so it creates, the facility creates ghost patients, and they go in the morning, they come lunchtime, they come, but they don't know that the system picks. We have one patient whose dependent children were 381 in Duale County. In Duale County. And we are giving such patients, we are giving them to the DCI, and we want to, the DCI will ask, can you show us your 371 children? Because the system is speaking. It's not human beings. This system looks for patterns. It will even tell you how many surgeries have you done. Yeah, for dialysis, most Kenyans who go through dialysis, there are two, fully paid by SHA. There are some who go the third one, which they have to pay. If we see this patient going for 10 times dialysis, then that's not a dialysis patient. So the system has really helped us. This system, Honorable Speaker, has what we call AI-driven fraud engine. It's very active. It detects anomalies in real time. For instance, the system flagged the facilities claiming for procedures that they lack equipment to perform. We found one facility in a county where they told us level 3, they said they are doing C-section. So I walked into that facility. And I asked, the governor said that facility cannot do C-section because there's no theater. So I told him, let's go to it. And when I went and we found the gentleman running the place, the first question I asked him is, take me to the theater. And he says, I have no theater. The second question I asked him then, where are you doing these C-sections? Because you have claimed 65 C-sections in the last 2 months, which we have rejected, we have not paid him. So the engine really helped us. The engine also helped us inflating bills for patients who never walked through their doors. Following these system flags, Honorable Speaker, we have engaged the Director of Criminal Investigation to conduct deep investigation. I can confirm to this House, the DCI has so far concluded 24 files for 24 facilities implicated in fraud. Two of the former CEO of SHA are before court. A number of staff of SHA are before court. A number of owners of facilities are before court. 25 doctors, SHA has withdrawn their rights to access because the system picked a pattern of doctors in operating in 10 counties. The doctor is in Homa Bay, then he's in Kisii, then you'll find him in Garissa, then you'll find him in Malindi. So the system picked, and some of them were involved. So 22 doctors have been denied their access rights to the portal of SHA. They can go and treat somebody, but if they treat somebody, they cannot do it where the reimbursement of the patient is done. We have also denied rights to, I think, close to 36 clinical officers who we found them in fraud. Files for facilities such as there was a facility called New Manyalo Nursing Home and Brimaxa Hospital. These have already been forwarded to the Director of Public Prosecution. Directors of these facilities have been arrested and charged, and we are not sparing, and I want to say that both the leadership of this House and the President have given us the support that we required. For us to achieve this, we must make bold decisions, hard decisions, and we must always work in the interest of the people. And Honorable Speaker and members, let me be very clear. Kenyan money will not be stolen. The digital system we have built is a fortress. It's like Fort Jesus. It will allow us to track every shilling from the moment a Kenyan contributes. to the moment that shilling pays for either a pill, a medicine, or a procedure in a theater. If you attempt to steal from the sick, the system will catch you, and the government will prosecute you. That is the new order of the day. If you steal from our sick, the system will catch you, and the government or President Ruto will prosecute you. We have further secured, Honorable Speaker, digital sovereignty through our collaboration with the United States government through the data sharing agreement, which I have shared with Parliament. I am ready to defend it. That data sharing agreement, Honorable Speaker, is solid. It's done by our lawyers, and it even says where the laws of the two countries contradict, the Kenyan law supersedes. The people who have gone to court are the civil society and the NGOs who used to eat this money historical. It is not us. The Kenyan patient, the HIV patient, the malaria patient is important. No system we have is important. No system we have can function without hands that heal. And I want to thank this House for approving the budget that has stabilized our workforce. The first day I went to Afya House, I was welcomed by UHC staff demonstrating and doctors. This House has really helped me in approving a budget that has stabilized the workforce. Today we have posted our interns, we have transitioned our UHC staff to SRC rates, and by June this year, in the division of revenue bill, we will transfer the whole resources to the equitable share so that our counties can now absorb them as permanent and pensionable. Honorable Speaker, I must speak especially about community heroes, community helpers, or tools. Today, they served with heart that they lacked the recognition. That changed in September of 2022, when Kenya took a bold step at a national event presided over by President Ruto. The government formally recognized and engaged 107 frontline community health promoters. These frontline workers, they are no longer volunteers, they are paid, they are equipped, and they are digitized. And come July, all the 107,000 will enjoy the social health insurance premium cover paid by chain for health products and technologies. We are reforming KEMSA into a very agile, transparent logistic entity that uses digital tracking to ensure the last mile of delivery of our medicines. We must ensure that a mother in a remote village has access to some life-saving drugs as a patient in the National Referral Hospital. Madam Honorable Speaker, if you allow me, we have introduced, I think, yesterday. We also picked a pattern. The system has picked a pattern where 50,000 patients in a county referral hospital go through the compound is surrounded by a myriad of chemists and pharmacists. Even go to Garissa County Referral Hospital. PGH. I was there this weekend and I was asking, why are there so many cases? If the patient does not, because the system will know. If you don't, the patient does not, because the system will know. If you don't dispense medicine to a patient, then SHA will not pay for any medicine you claim. Since SHA started, about 946,000 women have delivered through the SHA system. As a country, 0.5. The Director of Medical Services here. And when we look at those 900 and plus women who delivered either through C-section or normal delivery, we have their names, we have their ID card numbers, we have their telephone numbers, we know their county, we know their constituency, we know the facility. That is how robust this digital system is. So to kill the story that there is no medicine in our health facilities, now, if you don't give a Kenyan medicine and you claim for it, then SHA will not pay you. Then what will you be forced? You'll be forced to give the Kenyan. And the Kenyan will know from the charter he was supposed to get medicine for free, particularly under PHC. So KEMSA, as of today, the reforms we have done, KEMSA has a refill rate of 91. April, they had only, in every 10 drugs required, in April of last year, KEMSA had only 5. Today, in every 10 essential drugs that you ask KEMSA, they will give you 9. And we want to take it to 10. And we want KEMSA to buy from the manufacturer so that we reduce the price of drug. The cost of care in our country, healthcare, is very expensive, members. You must interrogate that. In a number of parliaments, 11th, 10th parliament, that discussion used to come. Why do we have one doctor charging you consultancy fee of 10,000 or 8,000, and you have another doctor charging you 2,000? There must be a standard. There is a standard among lawyers. There is a standard among engineers. There is a standard fee that architects can charge you. We must have, and I am sure I can see Professor Golicha looking at me, but sometimes we have to say it the way it is. We have to say it because we are defending the Kenyan patient. Honorable Speaker, just to highlight, because it's a matter before court, the importance of the U.S. government-Kenya health collaboration. This partnership provides over $300 million annually in support of our HIV, malaria, and TB programs. As we move towards the sunset of some of this international support, and I want to thank this House, Kenya was the only country that was allowed to come and sign in State Department. We were the first country to sign globally. And we were the first country that were allowed to sign in Washington, D.C. And that's how important Kenya is a leader in the healthcare. And many countries want to learn the universal health coverage and SHA from us. And most of it is because of the laws that you have. Pay 120 county for 6.1 billion, which the government has 6.1 billion. You go to a hospital, go through a CT scan. That CT scan, SHA will pay. Part to the hospital and part it will pay. You will find a private wing. Today the number of referrals, very few Kenyans are referred to Kenyatta Hospital or Kenyatta University or MTRH or Jaramogi, because all our county hospitals now, majority of them have the latest equipment, dialysis machines, CT scans, mammograph. You'll find them in all our, reducing the burden. Kenyans used to die on the road. So when we talk about healthcare transformation with the support of our members, UHC is about ensuring that the quality of care received by a president is the same quality of care available to a peasant. To achieve this, we have entered into a strategic collaboration that are already bearing fruit. And I really want to ask my sisters who are in this room to listen to me. When I became the minister, that drug now is sold at 40,000. And that's why SHA is paying for the full treatment for our sisters and mothers who battle breast cancer. That drug cost was very prohibitive, and it was forcing families to hold fundraising or forgo treatment. Now under SHA, it's accessible at zero additional cost to the patient. We have also formalized our collaboration with Aga Khan University. I did a partnership with Aga Khan to allow SHA beneficiaries to access the specialized service like kidney transplant. You know what happened in Eldoret? And Honorable Speaker, I really want to indulge you today. An audit was done on what Medihill did in Eldoret. The way kidneys were harvested, the way foreigners were brought into to our country. A good report was done. Illegally young people without regard to safety and ethics that comes with it. So today a Kenyan of any status can walk to Aga Khan as long as he has a donor. Kidney transplant will be done at the cost of SHA, 1.2 million shilling paid for, pre and post. Aga Khan used to be a hospital of the rich. Today, if you go there under SHA, at the dialysis center, you'll find in Nairobi Hospital, Nairobi West, in Kenyatta, you'll find all that. There are many people who say SHA is not working. If it's not working, then how come 29 million people have registered? There are some of the people who are saying it's not working. They are very sad because their county is number 2 or number 3 in SHA registration. For example, Nyeri is number 3. Number 1 is Mombasa. Let's clap for Mombasa. Number 2 is Bomet. Number 3 is Nyeri. Number 4 is Kirinyaga. I can continue. But for our colleagues like me who come from the Asal, if I start naming the bottom, that is where we are, including my own county. And I have to say it. But we must clap for the counties. Elgeyo Marakwet, Kericho, among the top. Lamu, among the top. As small as it is. Honorable Speaker, we have also have an agreement with Nairobi Hospital, a historic collaboration for kidney transplant at SHA rate. Honorable Speaker, these collaborations translate to one simple reality. We are demonizing the walls between the rich man's hospital and the poor man's hospital. Under SHA, every Kenyan has a seat at the table of quality health care. Honorable Speaker, I now want to speak to key moral imperative. And I want our sisters to listen to me. And this is the health of our mothers and children. Every woman, every newborn, everywhere, agenda. And our rapid result initiative that we carried as a ministry last month showed that 26 of our counties have drastically reduced their maternal mortality rate and newborn child death. But we have 25 counties which are in the red. We are trying to make sure that those 25 counties, we have an engagement with them at the level of the presidency and the Council of Governors, and no mother, Honorable Speaker, no mother should die while bringing. We are not doing very well. We're losing a lot of mothers in our facilities. And I want us to clap for the people from the former Central Kenya. Can you clap for them? The maternal mortality and new child born rates are very minimal. Those of us who come from Eastern, Western, Pastoralist, Nyanza, Coast, we have some work to do. And I am ready to lead from the front. I'll work with the leaders. That we are losing more mothers in those regions than any other part. Honorable Speaker, let me talk about the Kenyatta National Hospital, one of our world-class milestone. When I founded Kenyatta, and I'm happy to report today, the chairman of the Kenyatta National Hospital, the former Secretary General of Kenya Red Cross, through his corporate network, today we are refurbishing 9 wards in Kenyatta at a cost of 270 million, paid for by the corporates, banks. He went to Equity, he went to KCB, he went to many other organizations, and today they are refurbishing at a cost. Today, Kenyatta National Hospital has established the state-of-the-art HLA lab for organ transplant matching, ending our reliance on expensive foreign laboratories. We are not sending now tests to South Africa or to the CDC Atlanta. Kenyatta National Hospital is doing and is doing a lot to our community. Record-breaking surgeries you watch in the news every day. Beyond our borders, we want to position Kenya as a leader in global health security. And we have formed the Kenya National Public Health Institute. We have expanded our laboratories and our emergency operation centers. We want to build a resilient system that can detect and respond to pandemics long before they reach our doorsteps. However, Honorable Speaker, these gains remain fragile without a very strong intergovernmental synergy. And I want to urge the National Assembly to ensure that health remains a whole of government priority. Health security is inseparable from the work of the Ministry of Interior, ICT, Education, National Treasury, and many others. Honorable Speaker, let me come now to the legislative agenda as I conclude. We laid the foundation and we have secured the standard of care. And I wish to bring to your attention that there is a bill before the House called the Quality of Health Care and Patient Safety Bill 2025. This bill is critical bill is already before the House. It went through first reading on the 14th of August 2025 and has been committed to our Departmental Committee on Health. This bill will guarantee the safety for every Kenyan patient. It establishes legal framework to ensure that the care paid for by SHA is care that cures, not care that harms. And I want to give an example. When there are two mothers, pregnant mothers sharing a bed, that is not care. Do we agree? When we have a mother or a patient, even male, on the floor of a hospital, that is not care. Particularly in a cold place like Nyandarua. Do you know, have you asked yourself why there are no more Kenyans sharing beds? Do you know what we have done in the system? Every hospital, in their license, they have their bed capacity. So if your hospital has 50, we will not allow you to admit more than 50. Two, in the old NHIF, the two mothers who are sharing the bed and the one on the floor, both the three of them were paid by NHIF. So they were making money. Now we have said, and we watch the bed occupancy. If I had the Digital Health Agency CEO, we could have shown you, you know, a good example, Kenyatta Hospital. Kenyatta Hospital ideally is supposed to have a bed occupancy of 1,800. But Kenyatta was admitting 2,200, extra 400. Today, if you go to Kenyatta, you will not find two mothers sharing a bed. But what I am doing is the system and administrative. I really want you to do that in legislation. We define care in that bill. A care of a patient, the dignity of the patient, the safety of the patient, the ethical standards of the patient are all defined in that bill. I really want to ask Honorable Speaker and members and our committee to fast track that bill in the first quarter of this year. It will really help us help our patients. Then we have a number of other bills that are in Parliament. The Health Act Amendment, the Public Health Act, the Tobacco Control Act, the Cancer Prevention and Control Act, the Food, Drugs and Chemical Substance Act, the Pharmacy. All these are amendments. They will really help us if they are fast-tracked. Honorable Speaker, finally, to sustain this momentum, we require your budgetary support. To clear the pending claims and ensure that seamless operations of free primary health care, we urgently require, we have already told the National Treasury, they have committed to us, but the Leader of Majority and the Chair of Budget can help us, them to release the 5.9 exchequer release so that we can pay facilities for the month of October, November, and December in the primary health care, in the dispensaries, and in the health centers. But they have said they will pay before the end of this week. We also wanted The projection deficit of the PHC, and the chair of budget is aware, is about 11.9 billion, and we want it to be factored in between now and June. We want it to be factored in the supplementary budget. When we were looking at the maternity package, we realized the people who design SHA and UHC, they have left a very component. There are places where our mothers deliver in health centers. They deliver even in dispensaries. And sub-county or level 4 hospitals are very far from them. And after that discussion, and we did a paper, the summit chaired by the President, the Council of Governors, we have agreed now our mothers, because we want to reduce the maternal mortality, maternal and child mortality rate, we have asked now to be given more resources of 2 billion so that our mothers can now deliver in health centers and in some dispensaries in some of our constituencies. Honorable Speaker, and this is just to save our mothers and our newborns. Honorable Speaker, I come with the very senior members of my ministry. If you allow me, PS Oluga is busy chairing. I left him in Nairobi to chair another workshop. I have PS Mary Mudoni of Public Health and Professional Standards. I have the first Director General under the new Constitution of Health, Dr. Amoth, Dr. Masi Mangangi, CEO, SHA. One of my directors from KEMSA, Operations, and then Terry Rotich, who's the head of legal in SHA. I think those are the ones. Yeah, I have another team, the gentleman at the far end, the two gentlemen are two directors with Social Health Authority. Honorable Speaker, just to conclude, the state of our health care in our country is transforming. We have moved from a deficit-ridden NHIF to a more surplus-generating SHA. We have moved from a paper files to digital superhighway. We have moved from volunteers to paid community health promoters. This transition is unprecedented. It is working. It's what President Ruto and his administration have promised, and I request your continued support as we anchor these gains in law and practice. Thank you very much, Honorable Speaker and members. God bless you, and I'm ready to answer. Just to, in case members have issues with the headline of today, on the headline, the 11 billion are the rejections I have told you. Those are money lost in the sense that they have claimed we have found them. They are remitting. Some of them are going to court. Some of them have agreed to return back our money. And we have not finished. We have, I don't want to, there are some things that belong to the criminal justice system. I don't want to speak for. I have the whole list. The biggest junk is the private hospitals, followed by the county hospitals, followed by the National Referral Hospital, including Kenyatta, MTRH. The lowest is with the faith-based hospitals. We have the names we can publish. There are rejections. They claimed for services they have not offered. And they have done all that I was telling you. And I am sure that many people, including those who are criticizing me, some of them, this morning they sent me a text message and they said those people must be prosecuted and they must return the money. You cannot eat the money that belongs to a patient in Kenya. Thank you, Honorable Speaker.
Thank you. Thank you, Waziri. Honorable members, you've heard the minister is with his team, Rachel. We're doing 10-10. Yes. Yeah? Oh, Dr. Nyikal first. Lower your hands. We promise to give Dr. Nyikal 3 minutes.
Nyikal, just 1 minute. Honorable members, for those who walked in and out, let us first of all give a round of applause to the Honorable Duale. Indeed, Honorable Speaker, the Honorable Duale has done very well. In terms of making a presentation, we can tell